And are we live?
Yes.
Great. Excellent. Welcome to Health Coverage Insurance and Financial Services. Thank you for being with us. Before we start, we have four public hearings, but I'd like to have the committee introduce themselves, starting with Senator Bailey, because she will have to be leaving us.
Yes, I apologize. I do need to run off and present a bill in another committee, but I will be back. I am Senator Donna Bailey. I represent Senate District 31, which is Buxton, Old Orchard Beach, and Saco. You're in good hands.
Thank you, Senator Bailey. Representative Mastracchio.
Good afternoon. I'm Anne Marie Mastracchio. I represent House District 142, which is part of the city of Sanford and the village of Springvale.
Good afternoon. I'm Rolf Olson, District 86, which is Raymond, Casco, Fire Island, and a bit of Poland.
Good afternoon. My name is Bob Foley. I represent House District 145, which is most of the town of Wells.
Good afternoon, everybody. I'm Representative Poppy Arford. I represent House District 101, the western part of Brunswick.
Hello, Representative Michelle Boyer. I represent House District 123, which is most of Cape Elizabeth.
Good afternoon. I'm Sally Clucci. I represent House District 52, which includes the communities of Bowdoin, Bowdenham, and Richmond.
Representative Flynn, would you like to introduce yourself? And make sure you pass that down.
On its way. Hi, Representative Paul Flynn, District 63, Winslow, Albion, Freedom, and Unity Plantation.
Thank you. And I'm Christy Matheson. I represent District 151, which is Kittery, and I serve as the House co-chair. We are going to start a little out of order with our public hearings today. We'll be starting with LD 2011, and this is an opportunity for the public to come forward and testify either for, against, or neither for nor against our bills in public. Sorry about that, Anne Marie. I should have told you that. My apologies. If you don't mind checking in at the rostrum when you come up, and we will be doing a 3-minute timer during the testimony, and Representative Mastracchio will introduce her bill.
Representative Matheson and fellow members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. As you know, I'm Representative Anne Marie Mastracchio, and I'm here to represent LD 2011, an act to remove the Maine Care program from the prescription drug benefit provision in the Maine Insurance Code on behalf of the Office of Maine Care Services within the Maine Department of Health and Human Services. This bill proposes to remove the Maine Care program from the definition of carrier from Chapter 56C, Health Plans that Provide Prescription Drug Benefits of the Maine Insurance Code. This simple change will provide needed clarity, but would have no substantive impact on health coverage. The department is here to provide further details on the bill and the positive impact it will have on their work. Thank you for your consideration. I know they'll be happy to answer any questions you have.
Any questions from committee members?
Thank you.
Seeing none, thank you, Representative. I'd like to offer time for testimony in favor of this bill. Please come on up. Thank you. Welcome.
Hello. Senator Bailey, Representative Matheson, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Kristen Merrill, and I serve as the Acting Associate Policy Director of the Office of Maine Care Service within Maine Department of Health and Human Services. And I am here today to testify in support of LD 2011, an act to remove the Maine Care program from the prescription drug benefit provision in the Maine Insurance Code. My team and I greatly appreciate Brett Mastracchio's support for sponsoring this department bill on our behalf. This bill has no impact on the Maine Care coverage policy and only removes the Maine Care program from the definition of carrier for the purposes of law governing health plans that provide prescription drug benefits under Chapter 56C, Health Plans that Provide Prescription Drug Benefits of the Maine Insurance Code 24A MRSA 4347. This particular provision routinely causes confusion about the applicability of Chapter 56C for the Maine Care program, as no other provisions of Title 24A apply to Maine Care. The office frequently responds to bills proposals that include to seek or to amend Chapter 56C only for clarification on whether the proposal intends to include main care or not. These requests for clarification commonly result in the determination that there is no impact to the main care program. Therefore, the department suggests removing main care from the definition of carrier in Chapter 56C. Doing so would provide clarity, ensure the main care program is not unintentionally impacted by future changes, and have no substantive impact on main care or other health coverage. Should the committee intend to impact main care with any bill in the future, that could be accomplished by expressly including the program or by amending the main care statute directly. Thank you for your time and attention. I'd be happy to answer any questions you may have and make myself available for any questions at the work session.
Thank you. Are there any questions from committee members? Seeing none, thank you for your time.
Thank you so much.
Is there anybody in the room who would like to testify in support of this bill? Is there anybody online? Is there anybody in the room that would like to testify in opposition to this bill? Anybody in the room that would like to testify neither for nor against this bill? Seeing none, we will close the public hearing for LD 2011 and open up the public hearing for LD 2019. Representative Lucci will introduce the bill. Thank you. Thank you, Representative.
Good afternoon. I'm Sally Clucci. I represent House District 52, which includes the communities of Bowdoin, Bodenham, and Richmond. And I'm up here today to present this bill on behalf of our committee chair, Rep. Christy Matheson, from District 151, which is part of Kittery. So I'm going to read this as if it was Rep. Matheson reading this bill. So I am pleased to be here today as the sponsor of this Department of Professional and Financial Regulation Bill, LD 2019, an act to amend the law governing licensure of wholesalers and manufacturers under the Maine Pharmacy Act. This bill amends the licensure requirements such that it licenses without delay certain pharmacy wholesalers and manufacturers that are either not subject to the registration information issued by the U.S. Department of Justice Drug Enforcement Administration and registration information issued by the U.S. Food and Drug Administration, or those who have not yet obtained the required federal certifications at the time that they apply for licensure. The information must still be submitted, but can be sent to the Board of Pharmacy later once it is obtained. Thank you for your attention. I will defer all questions to the chair of our committee. But we also recommend that the people reserve their questions for the representative of the department who's going to share some more information on the bill.
Thank you, Representative. Any questions from the committee members for the chair? Seeing none, I'd like to introduce anybody who'd like to testify in favor of this bill. Welcome, Ms. Valancourt. People can talk. Everybody's so quiet in here today.
We're so
We're so impressed with this department bill. Go right ahead.
Thank you. And with that, good afternoon, Representative Matheson and members of the committee. My name is Penny Valancourt, Director of the Office of Professional and Occupational Regulation. As you've heard me testify before, OPOR has 38 licensing boards and programs, including the Board of Pharmacy. Thank you for the opportunity to provide testimony on behalf of OPOR regarding LD 2019. As you know, the board's sole purpose is to protect the public, and it does so by identifying minimum standards for licensure, investigating allegations of unprofessional or incompetent practice, and imposing discipline when deemed appropriate. The board issues licenses to qualified applicants in two general categories: an individual seeking authorization to practice pharmacy, and entities seeking authorized practice to engage in the dispensing, delivering, or distribution of prescription drugs. Currently, there are 5,545 actively licensed individuals and 1,984 actively licensed entities. LD 2019 really is a technical fix. There are a number of provisions in the Pharmacy Act that require either a DEA or in combination an FDA number in order to qualify for licensure. For example, retail pharmacies are required to have a DEA number in statute, but only once they obtain it. This is truly a fix in which current entities can't obtain a license without first getting the DEA, and they can't get the DEA without first getting the license. So this is a chicken and egg situation that we hope to fix by the committee's support to make these two manufacturers and wholesalers consistent with how we license pharmacies, in that if they are required to get an FDA or a DEA number, they will provide it to the board once it's obtained, not at the beginning of licensure, because they cannot get one without a license. So it kind of is a, well, it's not kind of, it is a technical fix that we hope that the committee will support. I really don't have any other information to provide as part of my testimony, but happy to answer any questions you may have now, or collect your questions and bring it back to you at work session.
Any questions from committee members for Ms. Valancourt? Seeing none, thank you for your
Thank you very
testimony.
much.
Is there anybody in the room that would like to testify in favor of LD 2019? No, do we have two online? Welcome, Ms. Memphis.
Okay, thank you. I just connected, so I wasn't sure if you called on me or not, but yes, good morning. Thank you so much.
Sure.
Thank you. My name is Kelly Memphis. I am with the Healthcare Distribution Alliance, HDA. We are the trade association for the nation's wholesale distributors. Our members physically deliver around 93% of all products to main shelves. And I'm here today just to express our support for this bill and to thank the department and the sponsor for bringing it forward. As the department shared, this will allow wholesale distributors to achieve licensure without any delay for them getting that licensure and continuing to deliver that product, due to the fact, as she highlighted, that currently they would need to provide numbers they might not be able to provide at that time of licensure. They cannot provide at that time of licensure. So just here to answer any questions if there are any, and to just express support and thanks for the bill.
Thank you very much. Any questions from committee members? Seeing none, thank you very much for your time. That was it for in favor, right? Edna? Thank you. Is there anybody in the room that would like to testify in opposition to LD 2019? Nobody online in opposition, right? Is there anybody in the room that would like to testify neither for nor against? Seeing none. No, all right. We will close the public hearing for LD 2019 and open up the public hearing for LD 2030. You're up again, Representative Mastroskia. Welcome.
Again. Good afternoon, Representative Matheson and fellow members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. I am Anne Marie Mastracchio, and I represent House District 142, which includes parts of the city of Sanford and the village of Springdale. Before you today to present LD 2030, an act to expand the scope of practice of independent practice dental hygienists. An independent practice dental hygienist, or IPDH, is an experienced registered dental hygienist authorized by state law to practice without the supervision, authorization, or on-site presence of a dentist. They're licensed preventive oral health professionals who can own their own practices, operate mobile units, or work in various community settings to provide care directly to the public. Their services are often more affordable and flexible, making them a good option for patients without dental insurance. More importantly, they accept dental insurance and main care. They typically perform oral health assessments, cleanings, prophylaxis, oral cancer screenings, fluoride treatment, sealants, dental radiography, and periodontal therapy, which includes scaling and root planing. Scaling and root planing can be painful, and some type of pain relief is often necessary to accomplish the treatment fully. This legislation would allow an independent practice dental hygienist to administer local anesthesia or nitrous oxide analgesia as long as the IPDH has the appropriate licensure authority to do so. They are currently unable to do this without the supervision of a dentist, general or direct. I urge your support of LD 1230, allowing IPDHs to practice to their full scope independently. Thank you for your consideration. And I'll answer questions, but I have a feeling there's plenty of people. You know, I'm perfectly willing to answer any questions you have, but depends how quickly you want to move things along.
Yes, Representative Flynn.
Thank you, Madam Chair. Just a very quick question. Under the supervision of a dentist, that is in person in the room?
No, yeah, well, it depends. If it's
Okay.
general, it's in the office, but direct is there
Thank
watching.
you. Thank you, Anne Marie.
Any additional questions from committee members? Seeing none, thank you for
Thank
your
you.
time. Is there anybody in the room that would like to testify in favor of LD 2030? Please come forward. Welcome.
Thank you. I'm presenting testimony for the past president of the Maine Dental Hygiene Association. And I am Bonnie Vaughn, and I am a dental hygienist registered in Maine. So Senator Bailey, Representative Masterson, and members of the Health Coverage, Insurance, and Financial Services. I'm presenting this for Tracy Dempsey, who lives in Bath and operates an independent dental hygiene practice in Augusta. And she's presenting this testimony on behalf of the Maine Dental Hygiene Association in support of LD 2030. Independent dental hygiene practices routinely serve adults covered by Maine Care as well as uninsured and underinsured patients, many of whom who have not seen a dental provider in more than 10 years. These patients frequently present with periodontal disease, that's gum disease, which requires deep scaling and root planing to restore their oral health. In a typical dental setting, hygienists administer local anesthetic to allow thorough subgingival instrumentation without effective anesthesia. These procedures can be painful. Unfortunately, many traditional dental offices do not accept Maine Care or uninsured patients, leaving this population to receive only topical anesthesia that is often inadequate. LD 2030 would allow independent dental hygienists to practice at the top of their license and provide necessary anesthesia to ensure patient comfort during invasive periodontal procedures. For nearly 3 decades, Maine Dental Hygiene Association and members with advanced board-approved training have safely administered local anesthetic and nitrous oxide under dental supervision. Practices are required to maintain written emergency protocols, report adverse events to the board, and ensure all providers maintain current basic life support certification. Board complaints related to hygienist and administration of this services have been exceedingly rare. Allowing independent hygienists to provide these services will expand access to care, especially for underserved populations in rural communities older adults, individuals, and disabled individuals. Patients with anxiety or pain would otherwise prevent them from receiving needed oral health care. So we support your, we look for your support for LD 2030.
Thank you. Any
I'd be
questions?
glad to answer any questions or also attend your work session if there's any issues.
Thank you very much.
You're welcome.
Representative Chimino?
Thank you, Madam Chair, and thank you for being here. Currently for an IDPH, do they all receive training in administering anesthesia?
Yes, most of them do because it's provided in their basic training. So the University of Maine, Augusta has a hygiene program. It's included in their basic training. Same thing with the University of New England. It's one of the courses that they take. Yes, as basic. Yeah.
Representative Hartford?
Thank you, Madam Chair, and thank you for being here with us today.
You're welcome.
Is it required for licensure that they do take the courses?
It's required for graduation.
Okay, great. And then how many other states allow for this?
Most states allow it under supervision, but not a lot of states have independent hygienists.
So I'm very interested in knowing how many states do
Allow independent?
Yes, for exactly what you're asking for in this bill.
Maybe a couple. Colorado has independent hygiene. I don't know if Anne Marie knows. Okay, we can find out.
Thank you very much. I'd appreciate that.
Additional questions? Representative Clucci?
Thank you, Madam Chair. So if a hygienist comes from out of state where they haven't necessarily been trained in this,
They could take a course
okay.
and get the training and then get the license because you'd have to get the board license too from the
Got it.
Maine Board of Dental Examiners.
Okay, so it wouldn't just come with being licensed in Maine. You would have to get
They would have to add it to their scope.
Okay, terrific. Thank you.
Additional questions? I think I just have a clarifying question, adding to Representative Clucci. So currently in Maine, it's part of the licensing and the school requirements. But if you came from another state and wanted a Maine license, then you would have to update that license?
You would have to add, you could get an RDH, registered hygienist license, but not the anesthesia permit part of our licensing.
So these are separate licenses currently
They're
in
called
Maine?
authorities.
Okay.
Yep.
Thank you. Additional questions? Seeing none, thank you very much
Okay,
for your
thank
time.
you.
Are there additional people in the room that would like to testify in favor of LD 2030? Welcome. Thank you. Welcome.
Thank you. Good afternoon, Representative Matheson and the distinguished members of the Health Coverage, Insurance and Financial Services Committee. I am Teresa Cahill, and I am the Executive Director of the Maine Dental Association. The MDA represents all dentists in Maine and is a statewide association dedicated to promoting health, oral health, and advocacy among dentistry. On behalf of the Maine Dental Association, I am respectfully providing testimony in support of LD 2030, an act to expand the scope of practice of independent practice dental hygienists. Passage of LD 2030 will allow independent practice dental hygienists, or otherwise known as IPDHs, who obtain appropriate trainings and then licensure authorities to administer local anesthesia and or nitrous oxide anesthesia. Currently, registered dental hygienists, or RDHs, with the appropriate licensure authorities are allowed to administer local anesthesia under the general supervision of a dentist, and nitrous oxide under direct supervision of a dentist. As IPDHs have more training than the RDH, the MDA believes that an IPDH with an appropriate licensure authority should be able to provide this without direct oversight of a dentist. With that said, as adverse events using local and nitrous are often reported to the Maine Board of Dental Practice, we would encourage all IPDHs utilizing these types of anesthesia to have collaborative partnerships with dentists upon whom they can call with questions and concerns if issues arise. Thank you for your time and attention. And I'm happy to answer any questions.
Thank you. Questions from committee members?
Yeah, I'm just
Representative Barford, if you want to turn your microphone on.
Thank you very much, Madam Chair. Yeah, whenever it comes to an expansion of scope of practice of any type, because I'm not a healthcare professional myself, I really try to understand what the background is. And so has this been attempted before, expanding the scope of practice in this way?
I think it's safe to say that the scope of practice for independent practice dental hygienists as well as registered dental hygienists has expanded quite a bit in the past several years. There have been multiple, and many of that is due to the fine representative at the end of the table. But there have been multiple bills that have expanded the scope of practice, and we have worked with the Maine Dental Hygienists Association. Now, if this were 10 years ago, I think everybody in the room would be surprised that the MDA is standing in support of this bill. But we've worked hard with the Maine Dental Hygiene Association to honor what they're trained in and ask them and work with them and regarding how to implement what they would like more to do in the state of Maine. I do want to say that Maine IPDHs are allowed to do more than almost all states. I'd be surprised if there were any other states in which this in particular was allowed to be done. There are only 10 other states that have IPDHs. So Maine is considered really looking at the broadest scope of access to care. So we have a lot of licensing opportunities and authorities provided to professionals, not just dentists. So to answer your question, this hasn't been provided, this hasn't happened before, which is why we're standing here. However, there has been as I said, a slow growth of expansion of what is in the scope of a dental hygienist. So we continue to support that as long as there's training. And not every state, I just want to go back to, not every state during the educational process will have that level of training. So it is important that they take the course and they apply for the appropriate authorities from the board.
And follow-up question,
Sure.
Once they receive in Maine, you receive this training in your normal course of the program that licensed you for this. And so once you graduate, is there, for this particular service, which they have not yet been able to do independently, and
Correct.
this is allowing them to do it independently, will they just be able to go out and do it? Or will there be a supervisory period or a mentoring period or anything? Or
if this scope changes, whenever the law goes into effect is when they can start doing it.
Okay.
Unless this committee decided to put some kind of supervisory period around that.
Mhm.
But that's my understanding of this piece of legislation.
And final question is, I think it's great we're leaders in terms of expanding access to care and professionally supported scope of practice expansions. I'm a big fan of that, as long as it also has a component that considers the patient safety aspect of it.
Absolutely.
So I am curious as to why we're the only state, at least from what you're saying, and nobody actually had the data, that is considering doing this.
I would say again, because somebody brought it up and there has been conversations we've had. The MDA has had conversations about this very, very thing, not necessarily nitrous, but local anesthesia. We've had a lot of conversations about local anesthesia. We hadn't really talked about nitrous, but it's in this bill. And we've had this conversation with the MDHA for a couple of years. And so No one else had brought it up before. We've been able to talk about it as a Maine Dental Association for a couple of years and really have kind of watched how the broadening of that scope for hygienists across the state has impacted and what's shown up at the board level for complaint cases and those kind of things. So we've been watching this process, and we are to a point. This might not have been a bill we were able to support a couple of years ago, but we are at the point now where we've seen that process happen and the patients and the conversations with the associations that we're able to support it.
Thank you very much.
You're welcome.
Representative Foley?
Thank you, Madam Chair. Thank you very much.
Sure.
I was just curious, do the independent dental hygienists, do they work a lot with the FQHCs, Federal Qualified Health Centers? I know-
is
I
not
know
my
a lot of
understanding.
them don't have dentists per se that are in those facilities.
Right.
So I'm just curious if this would be helpful for those, the FQHCs to provide this sort of advanced treatment.
So I think I'm going to just say that I believe that the hope is that the FQHCs will hire dental therapists, and dentists and hygienists. And so that I think is really the place. I think most IPDHs, there are many IPDHs who are, there are hundreds of IPDHs in the state of Maine. There are almost 300 the last time I checked. So many of them are working in dental offices. This is not going to impact them unless the dentist isn't, around, and then they'll be able to do nitrous because it won't be direct supervision. Because general supervision, the dentist can be anywhere. Doesn't have to be in the office. And then direct supervision, they're in the office. So for FQH, but the goal, I think, of most IPDHs is to own their own practice. And I think that's really where a lot of that's where the whole independent practice part of the IPDH comes out. So I don't think there's a ton of IPDHs. I haven't seen an FQHC website, and I've been looking at those because we've had a commission that was looking at different things. And so I was looking at the different FQHC's websites, and I didn't see very many IPDHs there. But the point of what I think you're trying to say for the dentist, the aspect that FQHCs, which I would challenge that they're looking for dentists, quite frankly, that's another story, is that they're really looking, a dental therapist fits much better in a FQHC setting than I think independent dental hygienist.
Thank you.
That's my
Thank you.
perception.
Additional questions from committee members? Seeing none, thank you for your
Thank you.
testimony. Is there anybody else in the room that would like to testify in favor of LD 2030? Seeing none, I think we have one person online. Edna, thank you. Welcome, Ms. Vanna.
Hello, can everybody hear me in the room okay?
We can, thank you.
Thank you. Good afternoon, Senator Bailey, Representative Matheson, and members of the committee. My name is Courtney Vanna, and I am here on behalf of the Independent Practice Dental Hygiene, or IPDH, Networking Group, and we urge you to support this bill. The IPDH Networking Group represents a majority of Maine's practicing IPDHs who practice all over the state. This is a group that is increasing steadily and becoming the fastest growing provider for patients with Maine care coverage, while we're seeing other provider types decline. Many patients are seen by IPDHs who have been without care for quite some time. This is often due to lack of access, and many do come to IPDHs with either pain or fear of pain, which increases their anxiety about dental care. Although many IPDHs have been trained to provide local anesthesia and already hold the local anesthesia practice authority that you've heard about this afternoon, the current scope language prevents IPDHs from being able to offer this pain-reducing service to their patients. For some of these patients, this means the difference between being able to access the care that they desperately need or continuing to go without. This bill amends the scope of the IPDH practice to allow local anesthesia to be delivered in their practice setting. A vote in favor of this bill is a vote in favor of increased access to care for patients who have concerns about pain during their procedure. We ask you to vote ought to pass on LD 2030 to support access to oral health care. I thank you all for your time and consideration of this bill, and I'm also happy to answer any questions.
Thank you very much for your time. There are questions from committee members. Representative Chimino.
Thank you, Madam Chair. Thank you for being here. Do you happen to know how the training differs regarding anesthesiology for an IDPH compared to an actual dentist?
Well, I can't speak to the dentist curriculum, but the training for a dental hygienist, and by the way, it's the same for all dental hygienists, whether they practice independently or not, is a semester-long course, so 14 weeks. It is extensive in not only sort of the administration, but also the pharmacology behind the anesthetic. I can say that dental hygienists are subjected to a unique form of torture that I think that the dentists avoid, and that they are required to give dozens of injections to each other, which means they're also receiving these injections, which I think is a difference between the dental hygiene and dentist curriculum. My understanding is also that the portion of the dentist curriculum is significantly smaller. I don't believe they have an entire semester-long course that is devoted to this training, but the dental hygiene schools in the state of Maine have been providing this level of training to dental hygienists for a number of years now, probably more than 2 decades, if I had to guess.
Representative Chimino.
Thank you. And do you know if this would also have a continuing education for this type of, for administering the anesthesia?
There is no, so if somebody has taken this curriculum and passed their assessments and has the practice authority that you heard about, there is no requirement for continuing education in this category. However, there are frequently courses offered, which clinicians will routinely just sort of go back to the basics and brush up their skills on. There's also what would be considered a continuing education course that is available to train people who may not have had this course during their curriculum. So let's say they graduated from dental hygiene school in 1990, this course wasn't available yet, or potentially coming in from out of state. I know that was a question that was asked. If somebody didn't receive this in their undergraduate curriculum, there are continuing education courses available that include both the hands-on component as well as the theory behind it.
Sure. Thank you. And then what about adverse reactions to the anesthesia? Is that something that's covered during the training?
Absolutely. Yep.
Additional questions from committee members? Seeing none, thank you very much for your time.
Thank you.
Is there anybody in the room who would like to testify in opposition to LD 2030? Nobody online, right? Anybody in the room that would like to testify neither for nor against? Welcome.
Thank you so much. Good afternoon, Representative Matheson and members of the committee. My name is Penny Valancourt, Director of the Office of Professional and Occupational Regulation, known as OPOR. OPOR has 38 licensing boards and programs, including the Board of Dental Practice. And thank you for the opportunity to provide testimony on behalf of OPOR regarding LD 2030. As I've stated earlier with testimony, the board's sole purpose is to protect the public, and they do so by identifying minimum standards for licensing, and they also conduct investigations and provide disciplinary action as deemed appropriate. So the dental board issues licensing to a number of dental professionals, and they practice as dentists, dental hygienists, denturists, dental radiographers, and expanded function dental assistants. Currently, there are 1,466 licensed dental hygienists. Within that number, 286 of those hygienists hold an authority to practice as an independent or known as IPDHs. Within that number of 286, 201 of those IPDHs hold a local anesthesia authority, and 78 of those individuals hold both a local anesthesia authority and a nitrous oxide analgesia authority. LD 2030 expands the scope of practice of an IPDH by making clear the ability to administer local anesthesia and use nitrous oxide without the supervision of a dentist, so long as the IPDH applies for and is granted the required practice authority from the board. Consistent with the testimony before the committee on bills related to expanded scopes of practice, OPOR isn't taking a position, but recognizes the collective efforts of the board, the regulated community, and the professional associations, and the work to continue to modernize the Dental Practice Act. And doing so to remove barriers so that qualified dental professionals can practice at the level they are trained and competent. Thank you for the opportunity to share my testimony. I would be happy to answer any questions now or at work session.
Representative Olson, thank you.
Thank you, Madam Chair. Just for clarification, it's a separate authority for local anesthesia versus nitrous oxide. So they'd need two authorities.
Correct. Actually, 3. So the baseline license is the RDH license, but if you want to expand in any way, you then need to get an added authority. So in this bill, the case would be you're an RDH, you would then get the authority to practice as an IPDH, and then you would apply separately for the authority to do local and the authority to do nitrous. It's a one-time only application. You don't have to renew it separately. It's all rolled into the RDH license renewal. And we did that work with the committee a few years ago to streamline the licensing for RDH. So they didn't have to hold out 6 different license types. So we're pretty proud of that. But yes, the first step is get the IPDH authority, the local, and then in the NOx, we call it.
Additional questions from committee members? Yes, Representative.
Thank you, Madam Chair, and thank you for being here. I always appreciate your testimony. My question is, again, just understanding the whole scope, which I know very little about. I'm still struck by the fact that there may not be any other state that has yet done this. And not that I don't think we should be a front runner. I just want to understand why other states, because I know that the lack of dental care, especially in rural areas, is prolific across our entire country. So what is the downside? We've heard about all the benefits, which I think sound very realistic and right on, and we want to do those things. But what are the risks? We have heard nothing about the risks of independent practice for these particular professionals.
I'm not sure I'm the best person to answer the risks because they're not known. We don't have any data to show that there is a potential patient harm. Rather, what I'd like to respond to your question is more about the history of how we got here today. I know you're super busy, but I just want to give a little brief window. This has been, I would say, 9 to 10 years in the making to be able to have hygienists and other allied health professions within the dental practice to work to their scope of practice without a regulatory barrier. So this to me is a long history of getting and increasing access while at the same time balancing the safety protections of the public. What we know is that hygienists are competent and trained to do and administer those medicaments. But we also know that the board has developed a very robust practice rule that's called standards of practice, by which all licensees of the board have to follow. So in terms of an IPDH doing these 2 expanded scopes, they're going to have to be really careful about patient selection, understanding the medications that their current patients are under, collaborating with any PCP and or dentists, but also understanding when it's time and how to respond to emergency situations when you do have someone who perhaps has an allergic reaction to local. It's more in the preventative side. So I'm anxious to see if the board will be reopening its rules, not just for IPDHs, but all providers who do local anesthesia, because we're seeing an increased number of adverse events. And this is really, I think, patients, based on my knowledge of issues that come before the board, patients presenting in a chair are not all that healthy, and they're on a number of medications, and they may have a reaction that takes a licensee by surprise. So that would be my risk for any number of licensees, just not the IPDH practice.
Thank you. Representative Chimino.
Thank you. Thank you. Do you happen to know if they are required to have malpractice insurance?
Not under the Dental Practice Act, they're not required, but to the extent that an employer or someone else covers them under their malpractice, I wouldn't have that information.
All right, because if the scope is changing, I'm wondering then, so doesn't liability? And so I'm wondering if that's something that we would need to require. And then if the company would, insurance company would even pick them up for malpractice.
It's a great
insurance.
question. I would not have the answer to that.
Okay, thank you.
Additional questions from committee members? Seeing none, thank you very much for your time. Is there anybody else in the room that would like to testify neither for nor against LD 2030? Do committee members have any requests for the work session before I close the public hearing? Seeing none, we'll close the public hearing. The last bill that we have is actually Senator Bailey's bill. So we'll take why don't we do the language review, take a break after that if she's not here, and we'll see if we can bring her in. Yeah, let's be efficient. Thank you.
She's gonna walk right in.
Thank you. I'm just gonna. Okay. Whew.
So Edna's handing out two things. One is the draft legislation that the committee will introduce in response to the recommendations of the commission to evaluate the scope of regulatory review and oversight over healthcare transactions that impact the delivery of healthcare services in the state. And you'll recall last Wednesday, you had a discussion of putting which recommendations of the commission you wanted to be put forward as legislation. So the blue is a compilation of 8 legislative recommendations based on the committee's recommendations. And then the buff colored sheet is the correspondence, the letter to the HHS committee about the 2 recommendations that the committee thought were more in line with the HHS committee's jurisdiction. 1, to establish a statewide health plan, and 2, the establishment of a task force related to long-term care. So I think I'll start by focusing on the communication to the HHS committee, which is on the buff colored sheet. They have a related bill, LD 1772, that includes, as I understand it, an amendment proposed by the sponsor that would include a component for the establishment of a state health plan. And so that work session is scheduled tomorrow. So I thought it would be important for the committee to get their communication to the HHS committee as soon as possible and in time for their work session. So on the buff colored sheet, you'll see just a draft memo to the HHS committee, letting them know that HCIFS received these recommendations as part of the report. And we're reporting out some suggested legislation to implement the recommendations, but you thought that these 2 particular recommendations you pulled out because they were more appropriately considered by the HHS committee as the committee of jurisdiction. The first recommendation, as I mentioned, is that the legislature reestablish statewide health planning services. And the second is a recommendation that the legislature consider the creation of a task force to study the demand for long-term care. So the memo just in line with memos we've sent in the past, letting them know that about these recommendations so that that committee can consider whether to put forward legislation to implement the recommendations this session. Perhaps they have a vehicle that they could use to do that, letting them know that we understand they do currently have this bill LD 1772 that includes a similar proposal. And with regard to the statewide health planning proposal, Representative Boyer and Senator Tipping had suggested the preparation of a draft, which we would include and share with them if they wanted to see another approach or an alternative approach to statewide health planning. And then the second recommendation relates to, as I mentioned, the establishment of a task force to study the demand for long-term care. So that's the draft of that memo. Happy to make any additional changes if there's anything particular the committee wants to add.
Any questions or discussion from any? Yes, Senator.
Thank you. I really just wanted to say thank you to Colleen because timing this to get it over to HHS for tomorrow is really masterful and I just really appreciate it.
Okay.
Thank you.
Thank
Okay.
you.
So, second real quickly is the blue. Again, based on the discussions that the committee had last week, I think that left you with 9 separate recommendations that the commission put forward that the committee wanted to introduce as recommended legislation. I combined 2 of them. So it would be 8 bills. We could combine them. We could combine them more, but I drafted them as separately. But I included them in, they sort of, if you remember when we talked about it last time, they sort of fell into 3 different categories. One was a category of making changes related to CON laws. One was a category making changes related to regulatory review and oversight. And the third category related to the sort of involvement in practices related to private equity investment in healthcare transactions. So on the blue sheet, there's 2 proposed legislative recommendations that would make related to changes in the certificate of need laws. The first one is the codification of the voluntary guidance related to maternity unit closures, making that requiring 120 day notice. That I think you kind of had seen a prior draft when the commission made its presentation to you. Draft legislation number 2, which is found starting on page 3, are the other 2 recommendations that were included in the report related to CON. One was to add criteria that would be considered by the department in reviewing a CON application to include consideration of a proposal's impact on affordability and accessibility for all Maine consumers. And then the second recommendation would be expanding the scope of CON review when there's a change in ownership of an entity that might involve private equity investment or participation of a real estate investment trust. So I combined those 2 into one proposal because they are making changes to CON. We could combine all 3 into one bill, but it felt like made sense to keep them separate. So that's on pages 3, 4, and 5 of the blue sheet. The third piece of legislation would be a recommendation that would require healthcare entities to provide notice to the Attorney General about a pending merger or acquisition. At the same time, a health care entity would be required to notify the FTC in accordance with federal law and regulations. So that also felt separate because it would go in Title 10, which is the chapter that provides the Attorney General's authority over and oversight over mergers and acquisitions generally, although this is specific just to healthcare entities, felt like that was the right place to put it for a draft. So those are pages 7 and 8. The next one is a draft proposal that would develop a regulatory process for review and approval of certain transactions when private equity, hedge funds, or management services organizations acquire a majority ownership interest in a healthcare entity, or when they take operational control over a healthcare entity. This again is the same proposal that the commission chairs brought forward to you, but it's a modified version of LD 1972 that just which was considered by the committee last session, which just really focuses in on the review of those transactions where private equity, hedge funds, or management service organizations are acquiring majority ownership or taking operational control. So those are that's on page 9, 10. Well, pages 9 through 20. Then that gets us to the last sort of category of recommendations, which relate to the role of private equity investment in healthcare. Draft legislation number 5 would be a prohibition on private equity companies or real estate investment trusts from entering into arrangements with healthcare entities for the sale and leaseback of the healthcare entity's main campus or primary location to the private equity company or real estate investment trust. So the way this is drafted, I looked at some other state legislation, may not be the right thing, but I think the right approach, but we'll have a public hearing on it. But Massachusetts has adopted this approach. It would prohibit the granting or renewal of a license to establish or maintain a healthcare entity if the main campus were leased from a real estate investment trust, you know, that in that sale and leaseback arrangement. So that's number 5. Number 6 on page 22 would be a prohibition on transactions involving healthcare entities in which the ratio of debt to equity is greater than 50%. This draft legislation was also shared and suggested with you during the original presentation by the commission chairs. I didn't make any changes to that. Draft legislation number 7 would be a prohibition on interference with the professional judgment or clinical decision-making of licensed healthcare professionals with independent practice authority. This again would prohibit certain activities related to care of patients. Like I said, the clinical decision-making, coding, those sorts of things. This is based on one of the states, I think it was Connecticut that I pulled out, but I might be wrong when I was looking at proposed legislation, but the commission itself looked at a number of other state proposals. And this is the one I chose, again, just for purposes of having a bill be brought forward before the committee. And then finally, the last one is a prohibition on provider non-compete clauses. And again, this was legislation that the chairs of the commission had drafted ahead of time and shared with the committee last week. So that ends up with 8. There's a possibility, as I said, of combining some if you wanted to combine them all by, you know, category. But as you discussed last week, there might be some overlapping jurisdictions with some of these. Potentially, they might not all be printed and referred to HCIFS. So it made sense to me to separate them this way, but happy to do it however you would like.
Thank you, Colleen. Questions, comments from committee members? Representative Foley?
Thank you, Madam Chair. Colleen, just a procedural. So these bills, we will send them over and then the House and Senate will decide which committees they go to. Thank you.
Yes, yeah, the process will be the committee has the authority pursuant to the resolve that established the commission to introduce the bills. And the process will be, the revisor's office will process them. They'll appear on the calendar, reported out by the HCIFS committee on behalf of, you know, the pursuant to the law, with an expectation that will be printed as an LD and referred back to committee. And then the legislature will make a decision as to where that appropriate reference would be. Most and like any other bill, I think the Secretary of the Senate and the Clerk of the House may make an initial recommendation, but the legislature will make the final decision as to where the bills would be referred to. Or even if the bills would be referred to committee. You would have that opportunity as well, if you decided not to. But they would be printed as an LD.
Thank you very much. Yep. Additional questions or comments? Seeing none, thank you,
All right, great.
Colleen.
Thank you.
All right, I think we will move forward with our last public hearing on the schedule, LD 2005. And Senator Bailey will be introducing an act regarding mail order delivery of prescription drugs.
All right.
Welcome.
Let me just say, I should maybe, leave committee more often because you guys are just so efficient. I'm going to start to take it personally. Good afternoon, Representative Matheson and fellow colleagues on the Committee on Health Coverage Insurance and Financial Services. As you know, I am Senator Donna Bailey, representing Senate District 31, which includes Buxton, Old Orchard Beach, and Saco. Today, I'm pleased to introduce my bill, LD 2005, an act regarding mail order delivery of prescription drugs. Just last week, one of my Saco constituents contacted me and expressed their concerns about delays in delivery and missing pieces of mail from the United States Postal Service. She wasn't the first, and she certainly won't be the last. Throughout my legislative career, I, as probably many of you, have received many complaints about the USPS. Each time I contact Maine's congressional delegation, I hear about a higher volume of packages, staffing shortages, Maine's older population, or something else. No matter the cause, the Postal Service is the responsibility of the federal government, and there's little that we as Maine lawmakers can do about it. That being said, out of all of these calls, I worry the most about constituents who receive their prescription drugs, some of which really cannot risk being skipped for even a single dose, in the mail. With this bill, I hope to alleviate some of that stress and worry, ensuring that Mainers have access to their medications regardless of whether or not the rest of the mail is on time. Mail order pharmacies, which ship medication to patients' home, protect access to prescription drugs for Mainers who cannot pick up prescriptions in person at the local pharmacies or who live in pharmacy deserts. My bill seeks to bolster those protections by ensuring mail order pharmacy users are guaranteed access to a backup plan should their medications arrive damaged or dangerously late. Despite the challenges with the Postal Service in pharmacy deserts that are specific to Maine, other states are already taking action to ensure that their residents can access their mail order prescription drugs. In Washington state, a new law requires that if a covered person uses a mail order pharmacy, the pharmacy benefits manager, the PBM, must allow for dispensing at a local network pharmacy if the mail order is delayed by more than one day after the expected delivery day, provide by the mail order pharmacy, or if the order arrives in an unusable condition. That law is the model for the bill before you today. I thank the committee for its time, and I'd be happy to answer any questions.
Thank you, Senator. Questions from committee members? Representative Clucci?
Thank you, Madam Chair. Thank you. The bill doesn't happen to say how much medication people should be able to get if their medication or their prescription is delayed. Is that something that you've thought about and that you think we need to consider including?
Yeah, I think it's a discussion we probably can have. I mean, I think I had in mind that they would just be able to substitute their prescription. So if it was 30 days, it'd be 30 days. If it was 90 days, it'd be 90 days. But I think that's something to discuss at the work session.
Yep. Representative Wilson?
Thank you, Madam Chair. Yeah, I mean, I guess it's probably more of a work session thing, but as far as some of the verbiage in there, especially with the latest change to the Postal Service, as far as what they're considering as their acceptance date, maybe we need to address something in there as to flow timing in regards to that.
Yeah. Yeah. Again, my focus is just, I want to make sure someone's prescription doesn't show up, that they're not caught short without the prescription drugs that they need.
Yep. Additional questions? I really appreciate this bill. I have constituents that are forced to do mail order for a number of reasons based on their insurance coverage and their PBMs. So they don't have any option with their medications and they have received it late or not ever received it. So it's a really important bill. So I appreciate you putting
Yeah,
it
this will
forward.
protect them as well. Yeah.
Thank you. Representative Arford,
Thank you, Madam Chair.
did you have a question?
Yes.
Okay.
Yeah, thank you, Madam Chair. And thank you so much for bringing this bill. I mean, it's a very straightforward bill. On the face of it, it absolutely makes sense. My only question is, what happens now if someone's delivery is late? or if it's arrives in unusable? I mean, are they just out of luck? I mean,
I think it depends on the mail order prescription company, the PBM, so I think it varies.
okay, thank you.
So I think that's another good reason though to pass a bill like this is to make it consistent so people know what to expect.
Thank you, Senator Bailey. I'll open up the floor to anybody who would like to testify in support of LD 2019. Is there anybody online, Edna? Is there anybody in the room that would like to testify in opposition to LD 2019? Oh, Sam. What's that? 2000. Oh, thank you. Sorry about that. 2005. Welcome.
Good morning, Chair Bailey. Good morning, or afternoon, Chair Matheson. I'm sorry. My name is, for the record, my name is Sam Hollmeyer with PCMA, which is the National Trade Association for America's Pharmacy Benefit Managers. And I'm here today to oppose LD 2005 as it relates to mail order prescriptions. PCMA and its members do offer mail order as a service where typically it's a 90-day supply sent to the patient's home, so they never have to leave their home, and it's delivered to their front door. And it's typically those conditions that are chronic conditions. So not an acute condition where you would take, say, a medication for like a week. It is those chronic conditions, things such as diabetes. Those are typically what mail order prescriptions are delivered. But things happen. There are weather delays. As mentioned, there were carrier delays such as USPS and other delivery services that are outside of the control of the PBM. However, we believe that PBMs do have workarounds that satisfy the needs for this bill. I do have some suggested changes if the committee does decide to move forward with LD 2005, and all of these are contained in the written testimony that is being handed out, and I will go through them very quickly. So in line 5, we would request to amend it to in-network pharmacies. Again, that is a measure to control costs. So again, those are in-network pharmacies within the patient's plan. Next is on line 7. So if there is a delay, we suggest that the bill is amended to a 3-day supply, because typically you're going to get that 90-day supply eventually. We think that getting a 90-day supply from the pharmacy is just going to add waste. To control costs, that's why we suggest the 3 days. And then finally, on line 8 of the bill, if the drug is unusable, we suggest an amendment to a 7-day supply. Again, PBMs or PCMA and its members typically have these workarounds already in place, but we respectfully request that the committee consider these changes. And thanks for allowing me to testify in opposition today to this bill. If you decide to move forward, I'd be happy to work with the bill sponsor and the committee on these suggested changes. And I previously mentioned, we want to ensure that these patients do receive their drugs in a timely manner, but we also want to control these costs as well. So that wraps up my testimony for today, and I'm happy to take any questions.
Thank you. Representative Mastracchio.
Thank you, Madam Chair. So I don't use a mail order pharmacy for anything, but I'm just curious, do they automatically, so if you have a 90-day supply, you usually have to renew the prescription if somebody has a prescription from say like Hannaford. Do the mail order pharmacies automatically send it back, or is it the same kind of thing where the person has to put in the request?
So thank you for the question. So typically when a patient gets set up on mail order, there is that setting up, I guess, initially. And depending on the medication and prior authorization, it typically is that prior authorization is set for a year.
Right.
So when a patient receives that drug, gets started on that mail order process, they will receive notifications on future shipments. So typically a patient will receive another shipment of their next 90-day supply prior to running out. So rarely do we see gaps and where a patient would have no drugs whatsoever. So you don't need to initiate it.
2 or 3 week. Do you know what the time period is? Because I know that when you call it in, I think it's about 2 weeks. When you have 2 weeks left, I mean, you have to give them enough time to be able to do it. And I just didn't know if with mail order pharmacies, it was the same process, or would you just expect them
Sure.
to send it to you as long as there were no changes? I'm just trying to figure out what the.
Yeah, I'd be happy to get clarification on that. So say if you take a daily medication, obviously, to answer your question, I think it depends on the medication. and I can follow up and find
All
a
right.
response for you. But a patient doesn't need to restart every single time their 90-day supply is up. The PBM will automatically ship them the medications, will automatically send them tracking information. And if there's any specific questions a patient might have, they can certainly answer those as well.
Can I follow up with one question?
Yes.
So you do recognize, though, that there are issues with the postal service these days. I mean, there are people in my area, I see it all the time, that don't get mail for 2 weeks. So I'm just curious if the thought is, I mean,
Sure.
there are people who have to get it through mail order
Sure.
pharmacies.
So PCMA's members don't only use USPS. They also use other carriers such as FedEx and UPS and whatever carrier service is best for that area. That all depends. It's all obviously all depends on geographic locations, but PBMs will contract with whoever can deliver the best
People are
service.
kind of at the mercy of that.
Sure.
One of the reasons I wouldn't deal with a mail order pharmacy right now is because of those issues.
Mhm.
I'm just wondering if you're thinking about in the future, I mean, it would seem to me that this kind of process that you'd be thinking about how you can address that, because it's not going to go away, because I don't
Sure.
see it getting any better.
Sure. Thank you for the question. I can dig deeper on that.
Representative.
Thank you, Madam Chair. Do any of the companies incorporate USPS tracking numbers on these orders?
Yeah, so
someone
the
says
so the
my order-
PBMs do send tracking information to a patient so that patient can track when and where that medication is. Yes.
So if the package doesn't come on Thursday, but it's due on Friday, would this kick in to get their prescription on Thursday? We're going to wait till Friday.
Again, a patient usually has some supply left, like the PBM won't. So say I am on a 90-day supply and my medication runs out tomorrow. I would already have that medication delivered, say last week. A PBM's not going to wait until you're on your final pill for you to get your medication.
But you had said they track, so they got a tracking number. So when they issue the order, they're tracking
Sure.
it through the U.S. Postal Service system, correct?
Yes.
Thank you.
Or whatever carrier they end up using.
Thank you.
Yes.
Additional questions? Yes, Representative Colucci.
Thank you, Madam Chair. Sam, you mentioned that the PBMs typically have workarounds if this happens. What are those workarounds?
Typically, it would allow for a patient to pick up their medication at a pharmacy, but it has like a day supply limit. And some of the suggestions I made in the bill are typical of what a PBM would recommend a patient do in that situation.
Thanks.
Additional questions? So what do you do for a rural state like us where they don't have a pharmacy? What is that work around for a patient if they don't receive the medication?
Yeah, so PBMs have network adequacy requirements. So a pharmacy needs to be within, and it depends on state, X amount of miles. So typically it's rare where a patient is unable to pick up a medication, whether it can't be delivered but for example, like PBMs don't typically mail a antibiotic because, you take that for a week. So they recommend a patient get that from a pharmacy, and PBMs have to have adequacy for a patient to be able to pick that up.
Okay, great, thank you. And you had mentioned they don't have to opt in to get their medications. That's like an annual opt-in or
So say you're with I go to my doctor and they prescribe me a new chronic medication. I can typically do it right there in the doctor's office. Again, it's all based on plan design and how your plan is set up, if you can do mail order, if it's required or not.
And for your PBM, do you have an opt-out requirement for patients? I'm only asking that because my experience with my PBM is that I have to opt out every quarter.
Okay.
Even though I opt out every
Yeah.
quarter. Do you have that? Is that a system?
That
for
is
you as
plan
well?
by plan. So the PBM doesn't make that decision. That is a plan choice
plan
on
choice.
on mail order.
Great, thank you very much.
Mhm.
Appreciate it. Additional questions? Seeing none, thank you for
Thank
your
you.
time. Is there anybody else in the room that would like to testify in opposition to 2005?
Not to make this all about me, but I noted things went pretty fast before because I didn't testify on any of the bills either. So,
True that.
but here I am.
That explains.
Yeah.
Welcome.
Well, thank you. Senator Bailey, Representative Matheson, members of the committee. My name is Dan Demerit. I'm the Executive Director of the Maine Association of Health Plans. The Maine Association of Health Plans and our members agree with the intent of LD 2005 and the importance of providing members with immediate access to their prescription drugs in the rare instances when a mail order delivery is delayed or spoiled. Carriers through their pharmacy benefit managers, that's why Sam went first, they partner with already provide consumers with coverage for a bridge supply through a local retail pharmacy to maintain their medications, access to their medications if their mail order delivery of medications is delayed or unusable. Sensible bridge supply policies keep members on track, help plans and providers prevent patients from receiving oversubscriptions of medications, and help limit expensive and unnecessary prescription drug waste. We oppose LD 2005 as drafted because it does not define or include limits related to duration or amount of bridge supply. My testimony includes language that would align the bill with existing practices being used by carriers today to provide members with urgent access to their medications. It's at the end of my testimony, and Mr. Hallemeyer's language is very similar to ours. I did want to share that home delivery, and we've heard some of this already in the conversation. You haven't even started my timer yet, so I feel pretty good about where I am, and I'm almost done. Home delivery pharmacies are.
We're moving pretty fast.
We're being efficient, but let's not get ahead of ourselves. I could.
I will start it.
I could testify on all 8 of those, certificate of need bills today. Home delivery pharmacies are convenient and they're effective. Insurance carriers and their pharmacy benefit managers are using the same innovations and systems as online retailers like Amazon to make sure their members can get affordable and convenient access to their prescription drugs without having to visit their local retail pharmacy. We're deploying online portals, phone-based apps, shipment tracking, pre-shipping, expedited shipping, order notifications, auto refills, and pharmacy locator tools. So make sure members receive their prescriptions delivered on time at their home or can access prescription drugs while traveling. I share with you a report from the United Health Group. It comes from Optum that provides examples of how home delivery service have an accuracy rate of 99.998%, owing to 10 safety checks for every order. You watch the videos and they have cameras, checking prescriptions as they move down the line. And 98% of clean orders are shipped within 2 days at no charge. So with that, and I provided access to a report with my testimony, we would urge that the committee consider these language changes as it moves into its work session, and I'd be happy to try and answer any questions that I can on this bill.
Thank you.
3 minutes left.
Any questions from committee members? Seeing none,
Thanks
thank
so
you for your
much.
time. There are additional people in the room that would like to testify in opposition to LD 2005.
Good afternoon, Senator Bailey, Representative Matheson, and members of the Health Coverage Insurance and Financial Services Committee. My name is Christine Ossenfort, and I appear before you this afternoon to testify in opposition to LD 2005. We are testifying in opposition to the bill as drafted. We're not sure that the legislation is needed today in the event of a delivery of a mail order prescription that is delayed or is delivered in an unusable condition. We ask the members to contact our our pharmacy benefit manager, or PBM, and they will work with the member to provide an accommodation that's appropriate for the situation. There can be variables such as, is the member completely out of medication? How many days do they have left? We are concerned that the proposal before you could lead to significant waste if the member gets duplicate prescriptions, one at the retail pharmacy and one through the mail order. But if you are interested in pursuing legislation, we urge you to include reasonable limitations, as other stakeholders have referenced, and to consider what requirements and restrictions might be appropriate if controlled substances might be involved. So with that, I'll conclude my testimony. Happy to answer any questions, and I will be present at your work session as well. And you didn't start the clock for me either.
I didn't, I know.
But I'm pretty sure I was.
You were definitely. Representative Boyer.
Thank you, Madam Chair. Thank you, Chris, for being here. Can you help me understand, what's the process now? So you contact your PBM by phone
Yes,
and like the wait time is?
I can get that. I don't know what their average speed of answer is, but I can
would
try to find out.
Love that. And then like the hours that generally that would be available for me, the potential customer who needs the meds to call. Thank you.
Sure.
Representative Chimino?
Thank you, Madam Chair. Thank you, Christine. I have a question. It's a hypothetical. So I've ordered medication, but it's on this rolling basis, so a year that it's good. What if I have no refills available to me on that medication? Let's say it's insulin and there's no refills available, it gets lost in the mail. Is an insurance company going to cover an entirely new prescription for that 90 days? And would you be able to get an authorization from the doctor for a 90-day supply as well?
So there actually is a law on the books today that deals with emergency refills of chronic medications. And if I remember the scenario that led to it correctly, it was more often due to sometimes people's prescription runs out and they haven't been able to get a hold of their provider to get a refill, or there's been a disconnect between the pharmacy and the provider. So I think that what you are describing would probably fall under that because it does allow the pharmacy to dispense a small amount in order to buy some time to get that refill. And there is also a parallel provision in the insurance code that requires us to cover that. I don't remember the details, but I'd be happy to look at that for your work session. And I suspect your analyst is very familiar with this as well. Probably more.
Additional questions from committee members? Seeing none, thank you, Ms. Austin.
Thank you.
There are additional people in the room that would like to testify in opposition to LD 2005? Seeing none, and we don't have anybody on. There are additional information that the committee would like to request for the work session? Oh, did I not do that? Sorry. I was wondering why I hadn't heard from you. Is there anybody in the room that would like to testify neither for nor against? Thank you. That isn't why we moved fast before. We actually did go through all of these. I get excited on the last one.
Thank you for
Welcome.
allowing me to come
Of
up.
course, sorry about that.
No, that's quite all right. My name is Margaret Reynolds. I'm here today on behalf of Cigna. Within Cigna, Express Scripts is our pharmacy benefit manager that operates under the Cigna group. So I'm going to speak to the experience of our members for Express Scripts. We certainly support the suggested language of my colleagues. Our mail order pharmacy has over 99% accuracy with our shipping, and we communicate with our members and meet them where they're at, whether that's via email, in a mobile app, and we have pharmacists available 24/7 over the phone. So we certainly want to make sure our members have reasonable access to their drugs. From a personal experience as a member, 2 weeks ago, I got an email letting me know my 90-day was coming. Then in the app, I could track where it is and it should be delivered tomorrow. I still have, I'd say 5 to 6 days on hand currently. So that's how it rolls. That's how we communicate with our members. And would ask the committee to support a reasonable approach to ensuring that there isn't excessive medication waste in our system. With that, happy to answer questions. And I would like to just offer that we will have a colleague available for your work session next week.
Thank you. Questions from committee members, Representative Foley?
Thank you, Madam Chair. Does Express Scripts have a relationship with a local pharmacy that if the situation was that your client couldn't get the prescription, that you can say, okay, go to X, Y, and Z pharmacy locally, they'll give you 3 days or whatever?
Yes. So in the app, you can track where your in-network pharmacies are. And as Sam mentioned, due to network adequacy, we do have retail pharmacy network in this state.
Thank you.
Representative Mastracchio?
Thank you, Madam Chair. Just following up on his question, do all the insurances have different policies though? Or all the PBMs or, I mean, there's no continuity. Like if I have one insurance one year and another insurance next year, it could be a whole different process.
It could be, potentially, yes. If you have a different plan or a different PBM servicing you, yes.
Representative Barford.
Thank you, Madam Chair, and thank you for being here. And I really heard what you were saying about how hard your company is working to make sure that your customers do not go without their very much needed medication. However, what I see this bill is doing is not in any way conflicting with that.
No.
Because this bill is only activated if they actually are in a situation where whatever you've done to make sure that they're getting their prescription fails. It's like a fail-safe. So in a sense, this is actually assisting you in your efforts, because in order for this to be activated, something must have failed in your system. So looking at it from that perspective, what resistance would you have to this bill?
I think our, I guess we'll call it opposition, would be if we're sending a 90-day script and it does get delayed by a common carrier, USPS, whomever, and it were to arrive on day 2, if the patient were to go to the pharmacy and fill another 90-day script on that day 1, then they have 180 days of medication on hand, which could lead to waste in the system. That's why we like the bridge approach, but I'm happy to work with this committee on what's reasonable.
Can I just, so correct me if I'm wrong, and I'm really interested in this, and it sounds like you're really making very sincere effort to make sure this doesn't happen. But wouldn't you have, what I understood you saying, if there was going to be a delay, you would know about that and you would communicate that to the patient and already be doing what this bill requires. You'd already be taking care of it to make sure that they do get a prescription.
Correct.
Because you know that it was going to be delayed because you track them.
Yes.
So this wouldn't be activated.
And they should already have some still on hand from the
Right.
previous 90 days. Yes.
So again, I just appreciate you explaining what you do, because I really do see a need for this that I hadn't seen before as a fail-safe. Thank you.
Yeah. Additional questions? I just had one question. You had mentioned, and I haven't read through this, but I will, the United, thank you. The accuracy, I'm curious where and what you get that data from. How do you know that a medication, other than someone might be tracking it? I know that my 87-year-old mother is not tracking it on her phone. That I know for sure, but I do know that she's getting it through the mail. So how are you getting this data? Maybe this is a work session. How are you getting that 90% accuracy, and how many complaints do you get, and how are those handled when medications aren't reached by the patients? I'm just curious. I just don't know where that, you said 90% accuracy. I just don't know where that data comes from. We'll have that for you for your work session.
Great, thank you very
and the
much.
complaint process.
Representative Clucci.
Thank you, Madam Chair. So I understood the 90% accuracy to be like the prescription was filled correctly 90% of or 99% of the time,
99%
not
of the
delivered
99.
99% of the time. Are we talking?
I'll have to provide the number of like delivery time accuracy. I don't have that, but
Okay.
yes, the prescription getting out of the door with the tracking number filled was the 99.998%.
Oh, thank you.
Yes.
Now
We'll get that for you.
so that's
So the
basically your
delivery
side of
is,
it.
yes, so your
It
question
doesn't-
is
it doesn't
delivery
take it-
accuracy, correct?
Yes.
Yes,
Which,
we
because
will
that's
have
what
that
this
for
bill
you.
talks about. It doesn't talk about whether or not you're shipping it,
Right,
right?
correct.
Is that how you understand this bill?
Yep.
Yeah, okay, great.
Yes.
Thank you. Appreciate that. Any additional questions from committee members? Seeing none, thank you very
Okay,
much for your
thank you.
time. Is there anybody else in the room that wanted to testify neither for nor against LD 2005? you. Welcome. Go right ahead, Ms. Cook.
Good afternoon, Representative Matheson, Senator Bailey, members of the committee. Thanks for the opportunity to be before you today. My name is Kim Cook. I'm an attorney with Government Strategies, and I'm testifying neither for nor against LD 2005 on behalf of Community Health Options. We appreciate the opportunity to provide the following information and perspective for your consideration today. We agree that Maine people need access to their prescription medications in a timely manner and appreciate that even a one-day delay can introduce stress and disrupt treatment regimens. We also believe that filling prescriptions through a mail-order pharmacy offers a multitude of benefits, including convenience, improved adherence rates, lower costs, and reliability. Higher medication adherence is associated with positive health outcomes, and studies have consistently shown that, quote, consumers who use mail order pharmacies are more likely to be adherent. The experience of our members is similar to research at the national level. Those who receive their prescriptions through mail order pharmacy have higher adherence rates. Based on our review of our members, we offer some data points just as a resource for you. Our members filling prescriptions through the mail to treat diabetes have a 92.7% adherence rate, while members filling that prescription at the retail pharmacy have an 82.2% adherence rate. Similar for some other conditions, chronic conditions, where there's more of a 10% more likely adherent rate with the mail order. Nearly 12% of all prescriptions filled by our members in 2025 were received through the mail. And we're using mail generically here. It might not actually be the U.S. Postal Service, but it is some sort of a delivery mechanism. And since the beginning of 2004, we have received just 2 complaints concerning delays that prevented members from obtaining prescriptions in a timely manner through a delivery service. While we can work with our pharmacy benefit manager to ensure prescription drugs are quickly mailed to members, we obviously have less control once with the common carrier. The agreement between us and our PBM acknowledges the importance of timely shipment through the inclusion of performance guarantees that ensure drugs are mailed shortly after claims are received. And I'd note, as you've heard a couple of times, typically the mail order is not timed to come the day before you need it or the day that you need it. They're typically timed to come 5 to 7 days beforehand. And so a one-day delay shouldn't result in a patient missing a dose. Not that that couldn't potentially happen and be a serious condition. We would urge the committee that if you move forward with the bill, we would encourage an amendment that is somewhat in line with what you've heard from some others previously, essentially to allow, in the case where somebody would run out of their medication, that you would allow a 7-day temporary fill as opposed to the full 90 days. And this is only in the situation where there's delivery delay, not in the situation where the drug arrives in an unusable situation. And then we suggest that you might address the copay or coinsurance required of the patient in a way such that if it's a 7-day fill, it would be prorated on the copay or the coinsurance. So it wouldn't necessarily be a full copay for that 7 days. So we've made a suggestion there. And with that, I'd be happy to try to answer any questions you might have or bring back additional information if that's helpful.
Thank you, Ms. Cook. Questions from committee members? Representatives. Olson, yes. Representative Olson, sorry. Okay, Representative
Thank you.
Mastracchio.
Thank you, Madam Chair. So is what you proposed here basically what your company does?
So I don't know how many days. So again, we've had like 2 of these. We were notified by our own members twice in our review over the last 2 years of a situation where there was a delay. I didn't ask them what the remedy is, but yes, I mean, we use a PBM that is Express Scripts. So it's essentially, yes, you work with the patient to make sure that they get, either if it's unusable, right, that they get the prescription at a local pharmacy, or they get some supply to get through that gap that they would be missing.
Representative Mastracchio.
So, and the adherence level that you talked about, is that, do you think it's the difference is because if you use a pharmacy and you go in like Hannaford, you have to actually remember to renew it. And in this case, they probably are just being sent it automatically so that they get it and they never run out.
Yeah, I haven't seen research that documented
just
why,
wondered-
but the thinking on it is both that because the 90-day, they're typically right at 90-day supply. First of all, you've got 3 months rather than every month having to go into the pharmacy, right? And it's going to show up at your door almost all the time, on time, right? As opposed to you having to call for the 1 month refill, or sometimes I think you can do a 3 month at the
Well,
pharmacy, but
most
you
of
have
the
to get there.
pharmacies are 90 days too. So
Yeah, there are a number of medications I know I've experienced it in my own family
that aren't.
where you go to the pharmacy and they're out of the medication. And so now you're in a position of, they might call if it's a Hannaford or
Right.
whatever, Walgreens, they might say, we can call to our other locations nearby to see who might have it. And now you've got to go over there. So there are those situations as well. And so I haven't seen any research on exactly the reasons for the adherence, but the national research is in line with what our review of our own members' adherence rates are, and being able to keep on top of not having gaps in their prescriptions or running out and those kinds of things.
Representative Olson, sorry about that.
No, it's all right. Thank you. Yeah, I guess I'm just a little surprised that on that 12% of all prescriptions being filled through mail order, seeing as it is a requirement under certain of the prescriptions under CHO that they can only be gotten through mail order. So I guess I'm not sure where that number would seem to me to be a little bit low.
Yeah, so I think there are some, I think, that are done through mail order, but this is the percent of all prescriptions filled. And I don't know what the percent, for instance, of chronic medications are, but my team did this internal review of their own numbers, and that's the number that they came up with. It's not that the vast majority of the prescriptions or the prescription medications for our members are somehow required to go through mail order. Because again, right, mail order is often used for chronic conditions where you're on the same medication for a long time and that kind of thing. I can look to see what that is, but
Yeah, because
it's not somehow the majority
as far
of
as I
things
knew-
required
As far
that
as I
way.
knew, the ones on CIS are required to be gotten through mail order.
CIS, I don't know that.
Chronic illness support. There's chronic illness support, which is part of all the CHO plans right now.
Yep, that could be the case. It's just not it's only 12% of those prescriptions filled by our plan are, I guess, part of that. But I can certainly ask them about that piece. Yeah. Again, part of our chronic illness support system, for those who aren't familiar, is that it essentially eliminates copays for, I think it's 9 different chronic conditions, to help members take away any barriers to care, receiving care for certain chronic conditions, all the common chronic conditions. And so it's all about adherence and ensuring that the continuity of care. And so I can look at how many members are on that and all of that, if that helps you understand it. But these are the numbers we've got.
Thank you. Additional questions? Representative Chimino?
Thank you. Thank you. A number of carriers have mentioned about having limitations as far as not doing a 90-day supply, doing a smaller supply, and I understand that. Waste has been cited. I'm wondering if there's been any concern about fraud with stuff being sold like on the market, black market, underneath.
We haven't seen that in our experience. As I said, we've had 2 in the last 2 years where members called and said, look, this didn't show up when it was supposed to, and I need to be able to get it somewhere else. So I think there could be a risk of that, but I think that would get caught if somebody was doing that kind of a thing, say they got a 90-day supply, especially of a controlled substance or something, and they were saying we would know, right, if it wasn't received. Now, maybe we wouldn't know if it was received in a unusable form, if somehow it was damaged or whatever. But if that happened more than once in a row, if it was happening, I think we would see that that pattern. So we were more concerned about, you don't know, you certainly wouldn't want that 90-day fill at the pharmacy when you've got a 90-day supply that's, a day or two late. And that was just how do you make sure patients don't run out of a medication that they need to be on? And so do this sort of 7-day supply, and then you don't have that concern about waste or fraud or any of it. And then just ensure that the patient is not overcharged at the copay or co-insurance piece.
Additional questions from committee members? Representative Harper?
If this is already, yeah, thank you, Madam Chair, and thank you for being here. This may have already been alluded to and I missed it, so I want to just make sure when you say in A, you say the temporary fill shall be subject to copay or co-insurance prorated to the quantity dispensed. I would be more comfortable if you said prorated to the quantity prescribed, because a 7-pill quantity, the per pill cost, just in normal business, is much more expensive than the 90 pill. 1 pill out of 90, that's why we go with a 90 pill, because you're getting more pills for less money. In other words, you pay, I have a prescription and so I know how it works. You following me?
This would, I think, very much depend on, typically the mail order, I think there is some level of discount, right? But we were more just suggesting that it wouldn't necessarily be fair to, if the person's copay for a 90-day is, say, $50, it wouldn't necessarily be fair for them to show up for a 7-day and pay the $50 copay. So we were just suggesting that it was just a consideration more for the committee to think about, if in the situations where you need to resort to going to the local pharmacy for this sort of gap while the delivery, the common carrier gets you your medication, that you think about what that copay should be, and you allow for that to be sort of proportional to the amount of the prescription. I'm not saying this is exactly how it should be, but it was just a more raised as a consideration for you all as you think about how to craft language for the bill.
Thank you.
Thank you.
Any additional questions? Seeing none, thank you for your time.
Thank you.
Are there any other people that would like to testify neither for nor against this bill in the room? We have nobody online, right? No. Cool. Is there any additional questions that the committee has for the work session? Representative Clucci?
Thank you, Madam Chair. So we heard from Optum and Express Scripts, and we've heard from Anthem, and I don't know who Anthem uses. Oh, I don't know. You guys use Optum for your PBM? No. Okay. You use, okay, great. Because I was gonna ask if we could find out if Caremark, CVS, Caremark, or whoever. It's this the same thing, right? Or no?
Carolyn.
Oh, Carolyn.
So maybe we could just ask that the carriers supply us who their PBMs are.
What I was trying to just understand is to just make sure that the PBMs that are used by the groups that are on that this committee regulates, right? So the exchange providers or carriers, and then the Capital RX, which is the state employee health plan, to just make sure that they are all sort of doing the same kind of practices. Is Colleen, or is that something we can find out, or? Okay.
So when you say the same type of practices, you're talking about the same type of 3 or 7 days responses if a problem happens, if they're aligned.
Exactly, to just make sure that we're not aware of PBMs that are actively not helping their patients when they get into a situation where there's a mail delay. That's what I'm looking for.
Okay. Any additional comments or questions for the work session? Seeing none, we'll close the hearing on LD 2005. And I think that's it for today. That's it. All right. Thank you very much.